Hello, and thanks so much for joining us. I'm Carol Jenkins, and the program is Black America. African American women have the highest breast cancer mortality rate among any U.S. racial or ethnic group. The mortality rate for Black women diagnosed with breast cancer is 42% higher than the comparable rate for white women, according to Breast Cancer Prevention Partners. The American Cancer Society says about 224,080 new cancer cases and 73,680 cancer deaths are expected to occur among Black people in 2022. On April 3rd of 2018, Dr. Alexea Gaffney, a triple board-certified infectious disease specialist, a pediatrician at Stony Brook University Hospital, received her own diagnosis of stage 3 invasive lobular breast cancer and is our guest today. Dr. Gaffney, thank you so much for being with us. And your story is a story of persistence and one that we need you to share with our audience in terms of making sure you get the care that you need. Please share your experience.
Yeah, thank you so much for having me on. I was diagnosed with breast cancer at the age of 37. And as you say, persistence. My diagnosis, I always say, was 2 years in the making. And hindsight is 2020. I now know that my breast cancer actually could have been entirely prevented. So, talking about persistence is important. So I was diagnosed with breast cancer because of a routine self-breast exam that I performed. I had been doing them since I was 20 or 21 years old. That was the age I found my first lump, and that turned out to be a benign tumor. And I was fine from the age of 22 until 35. 35, Sunday night, in the shower, doing a self-breast exam, and I find a lump. Bring it to the attention of my primary doctor, and immediately she hit me with the statistics. She's like, well, we got to act on this. We have to get it imaged. We got to get an ultrasound because you're a young Black woman, and if this is breast cancer, you're more likely to die from it. Like, those were words I was hearing 2 years even before my diagnosis.
That's tough medicine, to say, look, stop right now. But at least you had a doctor who did that.
Yeah.
What we're finding is that many doctors just don't get the difference between Black women and the rest of the population, or as we know now from Katie Couric, who has dense breasts, and therefore the finding of the cancer was more difficult.
A little more challenging.
But at any rate, your doctor said to you, we've got to move right away.
Right away. So I go get an ultrasound on a lunch break because, God forbid, I take a day off to take care of me. And skip back to my office with a preliminary report of benign findings. 3 days later, my primary doctor gets the final report. She sits me down in her office and closes the door, and she slides the report across the desk. And I don't even remember what it said.
Because you're the doctor, right?
Yeah.
So she slides it across.
She's like, you know what this means.
Right.
And I couldn't comprehend it. All I remember is that at the end of the report, it said BI-RADS 4, which means we don't know if this is cancer or not. Correlate clinically, get an ultrasound in 3 to 6 months, or do a biopsy.
3 to 6 months.
Yeah. So, the radiologist is in their dark room minding their own business, and they punt it back to your doctor who's front facing with you, has examined you, knows your history, and can take it from there. So me being me, I'm like, well, let's just do it again in 3 months. And again, she's like, nope, you're a young Black woman. If this is breast cancer, it's more likely to be aggressive, it's more likely to be late stage, it's more likely to kill you. You got to get a biopsy. And so that biopsy at the age of 35 was benign, but it showed signs that I was at risk for breast cancer. So I had a lumpectomy based on those biopsy findings, and the lumpectomy showed 3 types of abnormal cells. Lobular carcinoma in situ, which is kind of like a precursor to my invasive lobular carcinoma or my breast cancer. It also showed atypical lobular hyperplasia, which just meant that the lobular cells within the breast unit or the breast glandular tissue was just growing in abnormal proportions. And then it was within a fibroadenoma, which is the same benign tumor I had 15 years prior. So it was a sign that my body was capable of doing bad things. And so I was enrolled in a high-risk cancer clinic or breast clinic. So I continued to be screened from that point on every 3 months. And
So you're 35 now.
35, 5
So
years
every-
before
right.
the recommended age for a biopsy.
Right, right. And so every 3 months now you're on this trajectory when, you know, in hindsight, you should not have been waiting.
Right, in hindsight. But even still, there was 2 years between this first lump, this first biopsy, and my actual cancer diagnosis. So, you know, I had alternating mammograms with ultrasounds because I too had dense breasts, which increases your risk for breast cancer
Right.
and makes breast cancer more challenging to find. And I would alternate that with breast MRIs. And so, you know, that's
So all of this time you're like on the hunt. I mean, did you like think, you know, this is going to happen, or were you in denial in the sense of, no, this isn't going to happen because I'm doing everything that the doctor said to do?
Yeah.
As a lot of us believe,
Yeah.
you know.
I
mean, because I get a mammogram, it means I'm not going to get breast
Right,
cancer.
right.
But-
Screening is not prevention, and that's something we have to be able to distinguish. So I didn't just, you know, take it casually. I did everything I could think of to not get breast cancer or to try to reduce my risks. So,
Like
you know,
what? I mean, you actively said, I'm going to try to stop this in its tracks. What kinds of things did you do?
So I changed my diet and my lifestyle. I cut out red meats, I cut out pork, I cut out milk and dairy, you know, those carcinogen foods, those high inflammation foods. I began to exercise regularly. I exercised 6 to 7 days a week at the time. I lost about 24 to 26 pounds because I was obese at the time. And I know that extra fat tissue can produce estrogen, and estrogen can feed breast cancer cells. So I lost a lot of weight. I got active. I started eating cleaner and doing things to, you know, risk reduce, but things that I didn't do. I didn't get enough sleep. I didn't manage stress well. And all of that also has an impact on the body.
So for our audience listening to all of this, you've already heard some of the things that can contribute to cancer and the things that we need to do to keep it at bay,
Yeah.
if we can.
Right, if we can. Not all cancer is preventable. So if someone, you know, is taking risk-reducing measures and they still get breast cancer, it's not a failure. It doesn't mean you didn't do enough. You know, I didn't just throw that all away because I ended up with breast cancer anyway. But we have to really, really understand our finite risk, where they can be identified, like genetic testing. And then we can have, you know, real prevention, right? Preventative surgeries and things like that. So that
Genetic testing, rest, stress relief, the diet, all of these things
Yeah.
that you now prescribe and
Yes.
are aware of that
Yeah.
people need to do. So when you finally got the diagnosis, talk us through that.
Yeah, so prior to my diagnosis, my primary doctor, again, was like, you have ticking time bombs on your chest. Just cut them off. Get a prophylactic mastectomy and just get some new ones. Like, get some nice bigger ones. Like, why are you letting these bombs sit on your chest? And when I presented it to my breast health team, they told me it was too radical. No, it's too radical. You don't need to cut your breast off. So now I'm grasping at straws because I've been through this cycle of every 3 or 6 months biopsies. And I said, well, what about a genetic test? Could I get a genetic test? If I had a mutation, then that would make me a candidate for surgery. No, you don't qualify for that.
You don't qualify.
And it's not my field of expertise.
Right.
I'm, you know, told I'm being cared for by the best of the best, and I just took their word for it, you know?
Right, right. So,
Yeah.
but you're smart enough to know to keep at it. Most
Yeah.
patients, you know, when we're told by somebody who's been to school for a zillion years and should know what she is doing, you know, we sort of go away and wait.
Yeah. So I didn't do that. You know, I continued in my care. I was very diligent about going to my appointments, going to my screening, and doing the extra that I could do. So I'm having a regular follow-up with my breast surgeon. We just reviewed a mammogram and a breast ultrasound that I had days prior to our visit, and they were unremarkable. So, you know, I'm getting dressed, and he's like, all right, we'll order an MRI in 6 months. So he goes out the room to write the prescription, and before I even get out of my little pink hospital issue gown, he's back in there. And he's like, you know what? Your last MRI was 6 months ago. I want an MRI now. I just want to compare oranges to oranges. And I guess I never forgot that because of all that followed after that. So I get the dreaded phone call from having the MRI. Your MRI is very abnormal. We need you to come in for a biopsy. And when you come in for an MRI guided biopsy, the images that, led the doctors to this biopsy are up on the screen. So if I walked in from the door to the studio, on this screen are MRI images of my breasts, and it looked like someone took an orange and shoved it in my barely B cup breast. And
Are you kidding? That large?
Large.
The size of an orange?
It looked like somebody stuck an orange in my breast.
Unbelievable.
Yeah.
And this is after all of this testing,
All
but
this
it was the
ongoing
MRI that found it.
Yep. It had been less than a month between the ultrasound and the mammogram to the MRI. So we know the cancer was there. I just, have the kind of luck that I fall into the 15 to 20% of women who have breast tumors that are missed by a mammogram or an ultrasound. So if we're high risk, again, we don't walk away. We continue to push for screening. If we're not getting answers, if somebody's not ordering a biopsy based on a symptom or exam finding, in spite of normal imaging, get a second opinion. There's always a next step. There's always something more that we can do.
Right. Well, you did it, and the treatment for you afterwards was?
So I had all the things. I had everything. So I opted to have a bilateral mastectomy, remove or amputate both of my breasts. I did have reconstructive surgery later on. I had chemotherapy, which I had a 4-drug chemo regimen. I had radiation therapy, 25 rounds of radiation, and now I'm on hormone suppression therapy.
Wow.
Yeah.
Wow. But healthy and
Yeah.
here.
Yeah.
And conducting a practice, and then that's because of your persistence and your inside knowledge as
Yeah.
well. I was telling you before we started taping that when I called to get a doctor's appointment last week, someone said the earliest we have is May of 2023.
Yeah.
And we're talking I don't know, 9
Yeah.
months? You know? So what do we do with the medical system that now I think what's happening is the same thing that happened with me. Pandemic is over, so we think, or has eased.
Yeah.
So I'm now out going to the doctors again.
Yeah.
You cannot get appointments.
No, this is a very common issue. To get a subspecialty appointment could be 3 months, 6 months, 9 months. And so again, be persistent. If you can't identify another provider in your area, ask your primary doctor, who else can I go to? Who else can I call? Call your insurance company, right? Your insurance company knows who's in network, who they will pay for you to see, right? And so you can call them and say, who's in this area or within 25 miles or 50 miles of my home? Travel if you have to, especially if it's something that your life is dependent upon. If there's a symptom, you want to address that urgently. If you generally feel well, you don't have major health issues, and you're waiting on your physical exam, okay, maybe you can wait 3 months on that, but you can still try to get your screenings and things like that. Some things that women don't know is that in New York State and in several other states, you can self-refer for a mammogram. You just need to have a provider that you can identify, like your primary or OBGYN, for the radiology company to send the results back to. So if we're waiting, if we're behind on mammograms, then, self-refer.
So explain it in more detail. What does that mean?
So
I want a mammogram right now because I feel that I'm in danger.
Not in danger, but if you had symptoms, you really want to do that with a provider. But if you're a woman who's just 6 months behind, 2 years behind, 3 years behind because of the pandemic, and you just want to go for a routine screening, you can present to a radiology company that performs mammograms and say, I would like to have my screening mammogram, and here's my primary doctor's name and contact information. Here's my OBGYN's name and contact information. And they, by law, have to do that imaging for you and refer those results back to your provider. So that can speed things along for routine screenings.
And what kind of insurance requirement is
so
needed there?
So typically you would present your insurance card. It's a screening test, and again, it's state law, so they can't deny you that.
Even if you don't have insurance, can they deny you? Or?
No, so you can pay out of pocket. I just need to have a provider that you're going to refer this information back to.
Okay, so let's talk about the 6 month, because Katie Couric, who just made we're sending our sincerest wishes to her. Her
Yeah.
entire family has been touched by
Yeah.
cancer in some way or another. But she told the story of having delayed it for 6 months, suddenly realized, and not even thinking that for that short of a time anything was wrong, went and had a mammogram, and
Yeah.
in her case too, dense breasts.
Yes.
Which required, as I'm understanding it, ultrasound.
Yes.
So talk to us about that.
Yeah. So if you have dense breast tissue, right? So there's less fatty tissue within the breast. The fatty tissue you can readily see through. It shows up as black on the mammogram, right? But the denser tissue looks white. So think about a blizzard, right? And you're trying to pick out one special snowflake in a blizzard. How do you find that snowflake with all of the other snow in the background? So sometimes you need to have, well, not sometimes, if you have dense breasts, you should have an ultrasound coupled with your mammogram, and you should consider requesting a 3D mammogram, because a 3D mammogram is superior to a 2D mammogram for screening for women with dense breasts, which we see in younger women. Black women are more likely to have dense breasts. So, if we're starting to rack up risk factors here, we want to get the superior imaging study. So that's something to think about as well.
Let us talk about Black women specifically in terms of their danger.
Yeah.
Why this discrepancy in numbers?
So it's a number of things, right? Who did they study to define the treatment of breast cancer?
Clinical trials.
Clinical trials,
about,
right? Who was in the clinical trials? Not us, right? Historically, we've been a bit fearful to participate, but more recently, even though Black women are willing to participate, providers are not asking them to participate in clinical trials. So we only represent about 3 to 6% of the participants in clinical trials for a disease that we're the most negatively impacted for, right? We're getting it younger, we're getting diagnosed later, we're more likely to have aggressive tumor types like triple negative breast cancer, which has less treatment options and therefore a lower survival rate. And yet nobody's inviting us to the party when it comes to clinical trials. So, if you talk to Black women, they'll tell you, yeah, I would participate if I really understood what was going on. People think, oh, if I do a clinical trial, they're going to give me a placebo. There's no placebo in a cancer clinical trial. There's the standard of care, which you have to get, plus something that may be newer, better, cutting edge. And so...
Oh, it's interesting that you point that out, that we're not doing anything.
Yes, no sugar pills there. You're going to get a treatment, and the treatment is going to be the current standard of care for that diagnosis. And then the clinical trial aspect of it is something in addition to. And not all clinical trials involve getting a drug. Some of them are just observation. Let's see what happens. Let's see if this group has more negative side effects or more toxicity, or at what time frame should we really be looking for that. So we have to participate, but all of the discrepancies and outcomes is not just our lack of participation in clinical trials.
So one of the things that we, the general population usually follows is the suggestion from the medical community, after 45, after this, that, or whatever you do this, but we know that we've lost so many people because they just got the disease younger, out of the expected time frame. So how do we handle that if we're 25 and somebody says, no, you don't need screening for colon cancer, but you say, but I want it.
Yeah. So you have to know your family history. Family history can play a huge role in getting the test that you need in a timely manner. So typically, let's say someone has colon cancer in your family. My grandmother passed away from colon cancer. Because my grandmother had colon cancer, I should be screened at 40, not 50. Let's say if my grandmother got colon cancer at 40, she was much older when she got it, but let's say if she did, my colon cancer screening should start 10 years earlier, so at 30. So if we're armed with this information, then we have a leg to stand on when we're pleading our case to our medical doctors or nurse practitioners or PAs, whoever's taking care of us in the medical setting. But also we need that information so that if we have to have it out with the insurance company, we can justify why they're doing this screening test sort of off schedule, right? Because again, the guidelines are not based on Black people and our risk factors. The guidelines are based on white people. And we get diagnosed with cancers, breast cancer, colon cancer, prostate cancer, much younger than they do. We're more likely to get it at younger ages. We're more likely to die from it. So we have to be screened more aggressively. And sometimes we have to say to our providers, especially if they don't look like us, this is how it is for my community. And I'm not going to accept a later diagnosis because you're following guidelines that don't apply to me.
And in the case of breast cancer, too, we should point out that men are also susceptible to breast cancer.
Oh, yes.
I mean, I'm sure there must be a great still resistance for thinking about that if you're a man.
Yeah. So if a woman, if there's a strong family history of breast cancer in the women in your family, if the men in your family have prostate cancer, colon cancer, then the male family members are at risk for breast cancer. In general, the risk for male breast cancer is 1 in 813 men versus 1 in 8 women will get a breast cancer in their lifetime. That risk really increases, though, if there's a genetic risk factor for breast cancer. So I did a live with Matthew Knowles, Beyonce's father, and he had male chest cancer, is how he refers to it. And I think that language is important because men don't think of themselves as having breasts. So if we only speak about it in that way, we're not reaching the men who may be at risk. We're not helping a man who had prostate cancer or whose father had prostate cancer understand that he might get a male chest cancer. Men have breast tissue as well, you know.
So that speak to us about your practice, and I'm sure that there's a lot of what are you eating, how long are you sleeping, but give us a sample coaching, if you could, to our audience about what they should be doing now, whether they're women or men, if they're Black, certainly, and watching this program, but generally.
Yeah. Absolutely. I mean, my practice is very robust. I'm an infectious disease specialist. I have internal medicine training. I have pediatrics training. So I see people all over the spectrum, 18 and up, with all kinds of risk factors, including a number of breast cancer patients because it's a higher prevalence on Long Island where I live and practice. So when I'm counseling people, yes, I talk to people about their lifestyle, diet, exercise, adequate sleep, how they manage stress and anxiety and overwhelm, all of those things. We have to take care of our physical health, our emotional health, our spiritual health. So whether it's diabetes, someone who had a heart attack or a stroke, someone who's already had a breast cancer or another cancer diagnosis, or just somebody who's coming for a physical, I'm telling them, you need to get a minimum of 7, 8, 9 hours of sleep and make sure you have a good bedroom environment. You need to make sure you're hydrated, drink water, drink tea, drink and eat foods that are rich in antioxidants.
What's a good bedroom environment?
Oh, a good bedroom environment. So no TV on in the bedroom. For years, I did not have a TV in my bedroom. I have one now, and I have to say it's interrupting my sleep. But you should not watch TV in your bed. You should not do work or any wakeful activity in your bed. Beds are for sleep and sex, and your brain should be programmed to understand that. So, dimly lit room, maybe a little cooler than the rest of the house, a good blanket, maybe a weighted blanket, and a very dark environment when you're going to sleep. If the sun comes up and shines through your windows before you tend to be awake, then have blackout curtains, but open them wide open when the sun comes up and it's time to be awake. Our brains are so divinely created that we have a gland that senses sunlight and senses darkness and understands that in the light we should be awake and in the dark we should be asleep. So when we're with our phones and tablets and laptops in the bed, it confuses our brain about what we should be doing in there.
Wow. Well, it's the first time I've heard this kind of explanation in
Yeah.
terms of preventing cancer. I mean,
Yeah.
for many other things,
Yeah.
you know, yes, they talk about the bedroom environment, but it's essential. And for reaching out, if someone, I mean, we're going to put up numbers, hotlines and all, but what do you recommend if somebody says, wait a minute, I just don't know enough? You know, where do I turn for information?
So there's so many wonderful websites that you can look at. I think it's also, though, important to seek information from sites that are speaking to you. As a young woman who's dealing with breast cancer, I like Breast Cancer Research Foundation. The organizations that I partner with are BRCA Strong, which is an organization that supports women at risk for hereditary breast and ovarian cancer, but regardless of their genetic predisposition. For the Breast of Us is the only organization that is nationally recognized for all women of color dealing with breast cancer, and has some information centering on centering on young women of color.
Right.
What else is there? Of course, ACS, but the breast cancer community is kind of fighting with the American Cancer Society right now. We don't agree with their recent guidelines that discourage self-breast exams, which saves so many lives, but they still have valuable information there. And CDC.gov, everything is there.
All right, great. Well, I don't know. This has been tremendously informative, Dr. Gaffney. Thank you so much for being with us today. Congratulations on your recovery.
Thank you.
You know, continued good health. And for those out there who have learned anything, bedroom environment, diet, exercise, and being persistent with those doctors of yours, please do that. And if you haven't had your annual mammograms, now is the time. Many organizations, such as the American Cancer Society, offer support during and after your diagnosis. And we'll put those numbers up for you, or you can scan our QR code on the screen, see how advanced we are, to receive more information on our website. That's it for us at this time. Thanks to you for joining us. I'm Carol Jenkins. The program is Black America. And thank you so much.
Thank you for having me on.